Hi, everyone. Thanks for joining for this research talk. I'm Rebecca Borchering, a postdoc at Penn State, and I'm going to let you know a bit about my most recent work on multi-model outbreak decision support. Before I get started, I want to make sure that I acknowledge the huge team that, well, a subset of the huge team that worked on this project. Lots of organizations have contributed, and in particular, Cache, my supervisor, Will Probert, also contributed to some of these slides, and a wonderful group of people to work with. So before I get into this project in particular, I want to set the scene with multi-model decision support in general. So hurricanes, this is Hurricane Katrina, are an example of something that's very scary, can be devastating, and a lot of work and resources have gone into modeling the progression of hurricanes so people can take advantage of that information and inform decisions. So this is an example of several models being used. Forecasting, I think this is not a real hurricane, but the idea is that we can use information from multiple models to get a better range of, or cover more of the possibilities. And particularly for hurricanes, this idea has been extended into what's called the cone of uncertainty. And that brings together the information from many models and gives an idea of the range of places the hurricane might be at different points of time, which is really important if you need to evacuate or buy supplies, for example. So many multiple models have also been developed to address COVID-19, particularly for forecasting. So this is the COVID-19 forecast hub that's hosted for the United States. These are projections of deaths for just one state, for Georgia, and several modeling groups each week use the previous data and sometimes other data sources to forecast for 1 week ahead, 2 week ahead, up to 4 week ahead forecasts. And I highly recommend checking out their website to see other projections or forecasts, sorry. So multiple models is not a new occurrence for epidemiological systems. For both endemic and epidemic diseases, there have been diseases that several models have been produced for, these particularly influenza, Ebola, Zika, anything that, any pathogen of significant public health concern triggers lots of modeling efforts, excuse me. But the issue with having so many models can be that the multiple projections and forecasts can make decision-making difficult when there's uncertainty involved. So for an example, if we have, so moving to recommendations, models that incorporate interventions and are trying to evaluate interventions rather than the previous examples I showed were just forecasting. So here I have just an example, 3 different models, and they are evaluating 3 different interventions. So the question is, how should policymakers choose which model recommendations to use when developing policy? So we have 2 models that are saying that intervention A1 is good. Model 3 is saying intervention A2 is good. But It's not clear how to weight these models. Maybe model 3 is more famous and has performed well previously, so the decision maker might want to go with model 3, or they might want to go with the consensus of model 1, model 2. And this becomes even more complicated when you have so many models. This is a truncated list of all of the models. I don't recall, it's, I believe, over 20 different models just in this forecasting effort alone. And not all of the COVID-19 forecasting models or models in general are included in this particular effort. So how do we take advantage of all of the information being gathered by all of these different groups and models in order to inform our efforts to minimize the public health burden of the pandemic, COVID-19. So this is what I've been working on. And I mentioned my supervisor, Kat Shea, and I started a postdoc around May, June. But the idea behind the work that my team and I have been working on is how can we organize this information from multiple models and use it to inform outbreak management. And so there's a pretty intense, it's less intense than it looks, series of events that this structured framework was proposed in a journal in May that we have since then executed, and I'll talk a lot about that coming up. So multi-model outbreak decision support. There are 3 key fields or ideas underlying the work that was put into developing this framework. So relying on multiple modeling groups, as I mentioned, there are many pathogens, diseases that have work done or have inspired the use of the generation of many models. And there have been efforts in the past to, and currently, to work on aggregating or making ensemble models using those different models. But for this project, we wanted to combine that, not only just use the multiple models, but build upon that using expert elicitation theory that structures how to deal with judgments and choose, minimize bias, quantify uncertainty and risk, and systematically transform all of this information into something that can be used for a decision. So this is going to be a formal approach that we use that is aimed at providing information to decision makers that is actually able to be used and deployed. So this is a simplified diagram of the process that we implemented, but I'm going to go through it a bit more step by step and show you some of the pieces that come up along the way. And so our project, this particular realization of the process started in May, and we were looking at the reopening scenario, a few reopening scenarios for a county of approximately 100,000 individuals in the US. So that is the setting. And we provided baseline data for a particular county, but overall we're asking modeling groups to model a generic county with meeting some characteristics of the county. And I should mention a county is a small, so it's larger than a city, but it's a small, relatively small spatial unit in the US. And I'm using these orange boxes to highlight where data shows up. As we've learned throughout the week, the importance of connecting models to data is really important, and doing that in an informed way is something I wanted to emphasize how much data is involved in this process. So the groups were provided with data from a county on cumulative cases, cumulative deaths for COVID-19, and also some other characteristics of the county. For example, the age structure of the population in that county has become very apparent. Age really affects your risk for disease, in particular of COVID-19, and there are other aspects of the disease and COVID-19 epidemiology that may be reliant, or not reliant, heavily influenced by age. So now I'm going to get into the structure part of how we gathered information from different groups. So there were 5 objectives that we wanted these groups to evaluate. So cumulative infected individuals, COVID-related deaths, peak hospitalizations, probability of outbreak, and total number of workplaces or days, that non-essential workplaces were closed. And there was a 6-month projection interval that we were interested in, and asked groups to project these 5 different outcomes for. And then in addition to those 5 outcomes, we asked that groups project for 4 different potential intervention scenarios. So we have the extreme scenario of, I should mention, the county that motivates this had implemented full closures up to May 15th. And so the first intervention was maintaining those strict workplace and school closures. The second intervention was to relax current social distancing 2 weeks after the peak. So only opening non-essential workplaces after two weeks after the peak. The third intervention, opening non-essential workplaces when the number of new daily cases has come down to 5% of the peak. And then finally, the strictest scenario of immediately relaxing all current restrictions on non-essential workplaces. So everyone gets to open up. So another important aspect of this study was that we asked for full probability distributions, because we wanted to get an idea of uncertainty around the different projections. And so we did this by asking groups to submit a form or a spreadsheet or a CSV file with different quantiles, 1 through 100, to get that full distribution. So quantile 50 would be the median, and this way we could get interquartile range and the whole distribution, whole probability distribution. And all of the submission was done through the MIDAS network MMODS interface. And I will also point out, so we asked for metadata from the groups to know a bit about the models that they were using, and how they were dealing with uncertainty, and whether or not they were using any additional data. So how they were informing their parameter value choices, other sources of information like changes in mobility, basically any data set that they use to inform their model. We wanted to know about it, or evaluating differences that we eventually found between the models. And we also asked for the full-time equivalent, the amount of time that different teams put into this effort. So we put out an open call, which anyone could participate, and we ended up with 16 modeling teams that submitted 17 different so one group submitted 2 models, so we had a total of 17 models. And I'm just so excited, I'm going too fast, and it's dark. So we asked the groups to project once, and then so they submitted their results and this information, and then we had a group discussion where all of the teams came together on a phone call, and we talked about how everyone was interpreting the specifics of the setting, shared insights about what data sets people were using, and then groups were able to use this information to update their projection, maybe their model, and then so we asked the groups to run their models again, which may be new models or that have been built up. And then they were asked to do a second round of projections. And so I just wanted to highlight that really data is involved through all of the steps of developing the models, implementing the models, making the model projections. So after the 2 rounds, we aggregated the distributions that were provided and analyzed those and had a second discussion. And then eventually there is an additional, I don't think I'll get to this, but we did eventually come back and compare the distributions that we got from the modeling groups to the distribution of cases and deaths that we saw in counties of a similar size or similar counties of approximately 100,000 individuals. So our goal is to help a county executive determine reopening strategies or to choose amongst them, and to help understand what the best approach is and what trade-offs might exist under the different strategies. So the outcome, lots of people involved. This is the preprint that we've posted on medRxiv if you're interested. So I would also like to acknowledge all of the modeling teams that submitted results and forecasts to projections to this effort. So let me get to the results that came out of this. So this is a big plot with lots going on. So let me break it down. So in the rows, we have our 4 different interventions ranging from closed at the top to 5%, 2 weeks to open at the bottom. And then the columns are for each objective. So cumulative infections, cumulative deaths, peak hospitalizations, probability of outbreak, and days closed. And the colors are ranking the interventions from the lowest rank to the highest rank, where, so blue is the best for that particular objective intervention pair, and red is the worst. And so each panel has 17 submissions plotted, and then at the top, the aggregate of those submissions. So the aggregate distribution of the distributions that were submitted by the different groups. Okay. So I would like to point out a few things in particular. So we had very highly variable projections, but consistency in ranks. So you can see in this cumulative infections plot in the open scenario, models projected infections all over the place, up to the size of the county, essentially, down to no cases or infections at all. But there is a consistency in this being the worst possible intervention, which makes sense. Having the county completely open up is not, we wouldn't expect that to be a good intervention. And I'm going to pause for a second. So I realized just how dark it was getting, and for what it's worth, tried to change the lighting a bit. Okay, so consistency in ranks with variable projections, but when we see this consistency in ranks across multiple objectives. So these are the public health objectives that we consider: cumulative infections, cumulative deaths, peak hospitalizations. Closed was always ranked the best in the aggregate. So these are the aggregates that were at the top of the plots in the panels in the giant plot. And then 5% was the next best, 2 weeks was the next best, and open was the worst. So you can see the color ranking scale over here. And so in addition to ranking the different interventions, we also wanted to get an idea of risk or uncertainty. So I mentioned this when I first mentioned that we asked for distributions. And I'm going to focus on peak hospitalizations for now. So the medians would generally be, if you had just 1 point estimate for a model projection, it might be the median or the average. So these are the medians, and they're very close for these two middle, so not the most extreme and not the most relaxed intervention scenarios. The medians are very close. However, there is a difference between their interquartile range. So between the first and third quartiles, the projections, so these ranges give an idea of scenarios that are maybe not the most likely, but still have a reasonable or a somewhat likely chance of happening. And so this is the number of hospital beds, and peak hospitalizations is the objective that we're thinking about. So how many, so we want to think about expressing how our expression of risk might inform decisions. So for a decision maker, how many beds are available in the county might be important. So say 200 beds are available in a particular county, and the decision maker is thinking about which intervention should I choose to implement. While the medians are very similar, the uncertainty or the amount of the potential, so the range of projections varies between these two objectives. So you might, as a decision maker, not be comfortable going with the 5% or the 2 week scenario, because there's still a decent chance that your hospitalization will exceed the number of available beds in your county. And so for an example, this is if there were 200 beds available in a county, it falls within the interquartile range for the 2 week intervention scenario, but does not for the 5% scenario. So depending on your risk tolerant as a decision maker and the specifics for your particular context that you're making the decision within, having an idea of how much uncertainty there is for these different objectives, it can be really important. So why did we do multiple rounds? Well, one major reason was to reduce unwanted uncertainty. So this is a plot of the number of days closed for the closed intervention, showing both round 1 and round 2 reported projections for the different groups. So, or different models. In round 2, everyone lines up at 184, which for the closed intervention is, by definition of the intervention that we specified, what value it should be. But in the first round, we saw that teams were using different definitions than we intended, including stay at home, when those orders were put in place, when state of emergencies were declared, and this group had a waiting for compliance. So by having the second round of projections, we're able to bring everyone onto the same page. And then by doing that, the results of the aggregate distributions actually have meaning. So if groups aren't modeling the same thing or are using different definitions, then it's not really clear how to interpret that aggregate distribution. So we also wanted to encourage the expression of scientific uncertainty. And for the sake of time, I'm not going to get into that too much, but basically by having all of these modeling groups and aggregating over several models, we wanted to capture the or express the uncertainty that was abundant and is abundant in this current pandemic, COVID-19. In terms of transmission, all of the epidemiological processes, and I'll be happy to talk more about that comparison with you later. So there are many benefits to the MODS process. Hopefully I've hit on most of them. We did do the initial projections without a discussion prior to that. And that was important to get multiple perspectives. The discussion rounds were conducted anonymously to avoid bias and disproportional influence of established groups. The discussions explicitly planned for and involved the multiple modeling teams to minimize the differences in interpretation of the phrasing of the problem. And the structured decision-making that this procedure utilizes minimizes information bias and acknowledges everyone that's involved, shows the importance of framing the question. So with respect to what we've been learning about this week, the more specific your question, the more likely you'll be able to answer it. And this having precise definitions for the different pieces of the problem really come into the forefront in this process. And we wanted to be explicit about uncertainty and acknowledge that there isn't just a point estimate for what's going to happen. We don't know everything. There's stochasticity, there's uncertainty in what parameter values are. There's a whole range of different things that we don't know about the COVID-19 dynamics that we didn't want to force those assumptions to be made. So instead, to get an idea of the range of what the projections might be, hopefully taking into account those potential values. And I'll just mention again that it was an open call to modeling teams rather than choosing us for like pre-specifying a specific list of teams. Diversity of input is beneficial, and these are, this is a summary, I think, of the benefits and challenge that I just mentioned. And then the challenges, so setting up the framework was not easy. Coordinating between 16 teams did require a lot of time and effort, but we think that it was worth it. And the methods of uncertainty and in particular, submitting the full distribution with 100 quantiles were unfamiliar at the beginning for some groups. But for the second round, everyone was able to submit those full distributions. Okay, so again, I would like to acknowledge the wonderful, wonderful, wonderful MODS team. And this is just scratching the surface of everyone that's been involved in this project. If you would like to see the website that was used for this project, I've listed that here, and the preprint is available here. I'd also like to acknowledge my current affiliation, Penn State and NSF funding for my postdoc, and then obviously ICI3D and SISEMA for this wonderful opportunity to interact with all of you and share my research, share our research. So thank you for listening, and I'd be very happy to talk with anyone about this further. Just let me know. Okay, thanks.